During our time together this morning, we're going to have Alliance staff who will be monitoring our chat, and that's how we're going to get questions from all of you. So if something comes up while you're watching the film, please feel free to put it there. Also, when something comes up when we're having the panel discussion, please put your questions there and we'll make sure that we have some time to get through those. So again, when our team plays the documentary shortly, we're going to turn off all of your videos. We're going to mute everybody just to make sure that we can run the film nice and smoothly, and we'd have, hopefully, fingers crossed, no technology hiccups while it happens. So Lucy, whenever you're ready, we are good to go. We're also going to stop recording during the stop recording during the film, and then we'll pick it back up during the panel discussion. We're going to transition over to introducing our panel. So I'm going to let our folks on our Alliance team go ahead and start to pin our panelists up there. And I just want to start out by saying that was my third time watching this documentary in just about as many weeks. And I continue every single time I watch it, both to feel it deeply, to be impacted by it, but also just to really wish that it was required viewing for every person in our world who has a child in their life personally or professionally. I just really think it's such an impactful documentary. It also makes me really proud to be from Connecticut, seeing those folks from Clifford Beers and New Haven Public Schools, and gives me a lot of hope for our very small state of steady habits. So I'm just going to pause here and wait for our folks to go ahead and pin our panelists, and then we'll start introducing folks. Larissa, so just to answer the question that's coming in around where we found the documentary, we actually purchased the documentary because we were doing a public viewing. At one point, I believe it was up on a streaming service, but it is no longer on a streaming service. So the only place that we found really to watch it right now was to purchase it, unfortunately. We do have a copy here at the Alliance now, as you saw. So if it is something that you needed to view in a different setting, we could definitely talk about the ability to loan it out. All right, so maybe I'll just go ahead and get started. And then we have 4 panelists. If you all could just go ahead and turn on your video and turn on your microphones, then we will know that you're here with us, and we can go ahead and get started. Good morning, Melissa. Good morning, Sarah. Good morning, Representative Linehan. Good morning, Krystal. Thank you so much for being here. Hopefully all of you can see those folks too. We will have our staff here. Let me see, I think I can go ahead and pin all of you right now. So let's see. So Melissa, actually you're the one pinned, but I'll let other folks go ahead then, rather than trying to do it. They'll pin the rest of you also as we talk, to make sure everybody sees each of you as you talk. So I'm going to go ahead and just quickly introduce our panel and then just jump right into some of the questions that we have. I think after watching that, there surely is plenty to talk about. So please join me this morning in welcoming Melissa Merrick. Melissa is the president and CEO of Prevent Child Abuse America. Please welcome State Representative Liz Linehan, who is the chair of the Children's Committee. Please welcome Sarah Eagan, who is Connecticut's child advocate. And please welcome Krystal Rich, who is the director of the Connecticut Children's Alliance. And again, my name is Beth Hamilton, and I am the executive director of the Connecticut Alliance to End Sexual Violence. So I could not be more delighted. We found the perfect panelists to come and have this conversation with us. Each person comes with both an immense amount of knowledge, but also an immense amount of experience working on and around and in communities with children and around child abuse prevention and awareness. So I'm hoping if each one of you could start by introducing a bit about who you are and the work you do, and why you think ACE's data is critical to collect and incorporate into all of our work with children across disciplines.
Hi, everyone. I guess I can get us started. I'm Dr. Melissa Merrick. Nice to be with all of you today in Connecticut virtually. I am, as Beth mentioned, the president and CEO of Prevent Child Abuse America. We are the nation's oldest national nonprofit focused on the primary prevention of child abuse and neglect. So really trying to stop child abuse and neglect before it occurs. We do this work through evidence-based home visitation called Healthy Families America. That's in about 600 sites around the country. And we do it through a nationwide state chapter network. And we're so excited to be alongside Krystal and her PCA Connecticut team. to do this important work. Prior to joining this organization, I was a senior epidemiologist at the CDC in the Division of Violence Prevention at the Injury Center. And I had the great fortune of leading the Adverse Childhood Experiences portfolio of work for many years, about 7 or 8 years. So I was the lead scientist on ACEs, but what did that mean in violence prevention? Because at first there was no congressional appropriation to support that work. There was really no staff. There was really no kind of body of work. There was the early work that you saw featured here in this really powerful documentary that really linked ACEs to a whole host of negative health and well-being outcomes. Over 40 health outcomes to date have linkages with early adversity. So really, we took it as an opportunity to build a movement on how can we actually prevent ACEs. So it really, at CDC, fell within our violence prevention efforts, specifically our child abuse and neglect prevention efforts, which are around essentials for childhood, providing or promoting safe, stable, nurturing relationships and environments for all children. And of course, it took on a life, right? We see ACEs as a powerful and critical public health lever. If we have healthier children who don't experience multiple forms of adversities like child abuse and neglect, like sexual violence, like growing up in a home with untreated mental illness or substance abuse, parental incarceration, if we don't have that, we can actually achieve multiple of our nation's health and well-being goals. So I'm just pleased to be with all of you. It takes all of us and all of our friends to really champion this important area of prevention of early adversity and ACEs. So I'm so thankful to be here with my esteemed colleagues.
Thank you so much, Melissa. Representative Linehan, would you like to go next?
Sure. Thank you so much for having me here today. I just, hearing Dr. Merrick talk, I feel like I'm with my people. So I appreciate everything that you do and everything that people do on this panel. I'm Representative Liz Linehan, state representative from Cheshire, Southington, and Wallingford. And I am in my third term, I think. Wait, third term. I had to think about it. And my second term as chair of the Committee on Children in the legislature. And we are tasked with not only the Committee of Cognizance for the Department of Children and Families, but also really any kind of legislation that is supporting the safety, health, and well-being of children in the state of Connecticut. What we're talking about today is actually really appropriate for the work that I've been doing for years, but especially this year, because we have a package of bills that actually work towards the end goal that we all have here today of ending child abuse. And so I'll just do a very, very quick overview. We do have a bill that would collect ACEs data. I will be very clear. I know that there are some big supporters of this bill. That's House Bill 5698. But we also have a bunch of people who have had some concerns. And so I want to voice those concerns today because perhaps the people working here can give me some ideas on how to fix that. So right now, I did receive a letter from the Child Health and Development Institute, along with the Child Study Center at Yale, and Clifford Beers, and about 30 other people who are involved in adverse childhood experiences, whose concern regarding our bill was twofold. And yes, we are collecting data. We are looking to collect more data, but groups like the ACLU were adamant that it needed to be anonymous collection of data. And the doctors that have signed a letter to myself and my committee are extremely concerned about it being anonymous, because look, if a child says, yes, I'm being abused at home, but it's anonymous, how do we help them? So we are currently at an impasse, and we're trying to figure out exactly a way to satisfy the needs of everybody, which is really the problem when we are passing legislation. It's is there a way to satisfy everybody's needs without saying that we want to do with children? So that is where we're at today with this legislation. It did pass out of committee, so I do have the ability to keep working on it. but I'd love to hear, whether it be during this panel or beyond, kind of ideas on how perhaps we can achieve the goal of collecting data and providing anonymity when it's needed, but also having the services available to children who need it. One of the ideas that we're looking at right now is and I hope I'm not going too into this, but the city of Meriden actually has an algorithm that can possibly utilize PowerSchool to identify kids who click on that says, yes, I'm being abused, and that information can be sent directly to a school psychologist. Whether or not that's going to be able to be done right away, I don't know, but that is something we're looking at. So if anyone on the panel or beyond in our listening or watching universe is aware of anyone else who is doing that kind of work, I'm very, very interested in hearing that and knowing how well that's worked. Really quickly, I'll just go over very, very briefly that I also have another package of bills that are intended to help stop child abuse before it begins. My legislative experience is that in the past, I've really worked at punitive measures against abusers. And this year we're working on actually preventing child abuse in the first place, and specifically child sex abuse. And so we do have a package of bills that would actually educate parents and children on what grooming is. And then we also have background checks for camp counselors and coaches. And we've also added questions to the Youth Behavior Risk Survey, which is focused on adult sexual misconduct, the additional questions. And additionally, for the first time ever, we are mandating that if a school district in the state of Connecticut is chosen by the CDC to administer that they must do that. Currently in Connecticut, I think we have somewhere around 70% rate of people of district who comply. So we're going to be making that mandated. So I think that's kind of a big deal. We're really excited about that. 70% sounds good, but it's not good enough. So with that, and I also want to say my fellow panelist, Sarah Eagan, our child advocate, has been instrumental in this legislation. I can't tell you how many hours she and I have just sat down and discussed all the things that we want to do surrounding this. And so I would like to use my time on this panel to publicly thank Sarah and Faith Fosswinkle too, who I see is in the peanut gallery. They've been instrumental in this legislation coming forward and finally having its day. So that gives you some information and background on me, and I'll put my email in the chat for anyone who can see it to contact me if you have some ideas on how to help achieve our end goals. So thank you so much for having me.
Thank you so much, Representative Linehan. That was really informative. And I'm guessing you probably have some takers and having a follow-up conversation with you about how we can support those efforts, because I think you really bring up some critical pieces about how we both protect confidentiality, but how you also then get the support to kids and families who need it. So I'm going to ask you, Sarah, if you would please go next in introducing yourself and talking a little bit about your work.
Sure. Thanks, Beth. And thank you, Representative Linehan. Only three terms. I can't believe it. I feel like I've been here forever already. Great to be with everybody today. And, really powerful documentary. I had not seen that before, although I have, I know it's been screened a few times. I haven't had the opportunity. And, and as I watch it, I feel sort of I feel like these twin emotions at the same time. One is, real inspiration, because there's so much hope, and there's so many interventions that we can do that are relatively low cost, that are effective and supportive, and can make a world of difference across our landscapes. I also feel very frustrated watching things like that, because for some reason, sometimes we leave the low-hanging fruit, on the tree. And so the Office of the Child Advocate is an independent state agency charged with investigating and publicly reporting on the efficacy of publicly funded services for vulnerable children. That's a broad mandate, but the work that we do intersects with ACEs data and public policy regarding ACEs in every way, right? Because in some ways, the information that we're talking about here, the phenomenon of ACEs and its impact on children and families and adults, impacts every aspect of health and wellness policy, education policy. But a couple specific ways that I was thinking about during the film are the Office of the Child Advocate is a permanent member of the state's Child Fatality Review Panel, and I serve as the co-chair of that multidisciplinary panel. And my colleague Faith Voswinkle who is also on in the audience here today, does a lot of that work. And I'm sure that she would agree that where we see preventable child deaths, we very, very often also see ACEs. Where we see preventable infant deaths, the largest cohort of children to die for preventable reasons in the state of Connecticut, we often see multiple other stressors on families, the consistent with the information on ACEs. So there are big implications for child fatality prevention, not just in the abuse context, but across manner of death. Two, I think about, I'll tell you, what I was also thinking about watching this film. I was thinking about that three-year-old little boy who was killed in Hartford over the weekend, I guess two weekends ago. And I think about who the youth that are slowly being identified as allegedly responsible or in some ways connected to that child's death, who obviously died and was an unintentional victim of a homicide. And I think about, what would these children's ACEs scores be? How are we prepared to respond to the realities of urban violence? The children who feel that they have to carry guns in the streets of their community. I feel that sometimes we are so torn between wanting to support children and wanting to punish them. And in different communities, at what age that shift begins. But the video talks about this, this in the end of the day, this cultural touchstone of everybody is responsible for their own actions and everybody can improve themselves if they only have the will and the moral compass. That's the mentality that thinks that the answer to urban violence is building more prisons instead of investing in communities that we have abandoned. And it is possible to care deeply about the victim of shootings as it is the perpetrators of shootings. And I think about that little boy that we will review as part of the Child Fatality Review Panel. And I think, what are we committed to as an answer? These 15 and 16 and 17-year-old boys that get sent to the adult prison system are mostly Black. They are almost all from high poverty, high need communities. Our work tells us that the majority of boys incarcerated in our adult prison system have been involved with the Department of Children and Families for concerns of child abuse and neglect, often multi-generationally. That over a third of boys in the adult prison system, minor boys, live in families who have been involved with DCF more than 10 times for abuse and neglect. That they function at about the 4th grade educationally, that the majority of children in the prison system have an incarcerated parent. And I think, well, what are we going to do with that information? I'm sorry, I don't mean to go on and on either, but the implications are profound for what we're talking about here. And, if I had a magic wand, I would, which does not come with this job, but I would demand a statewide multi-agency partnership to develop health and wellness policies that are trauma-informed and ACEs responsive, that with implications for home visiting, prevention dollars, state Medicaid plan, and educational policy. And if we did that, and we have pockets of innovation across all of those systems, but if we did that in a deliberate strategic plan to have a state Medicaid plan that was responsive to what we know about ACEs, we could change the world for children and families. Of course, we have to be committed to addressing the information that we derive. We can't leave families struggling in in their communities without access to basic income, without access to safe and affordable housing and green spaces and clean air and good schools. We need to start investing meaningfully in the foundation that all children require and deserve. And then maybe we can talk about accountability. Those are my preliminary thoughts. Thank you.
Thank you so much. Thank you so much, Sarah, for that. I think that those are some, you're probably hitting on what many of us are thinking. And so, stating it so well. And I just really appreciate your vision. I think that you have probably folks around the table who would love to help you realize that vision and to be those collaborative partners in whatever way that we can to help that move forward. So thank you so much for bringing all of that to us. And then Krystal, would you please go ahead and share a bit about yourself and your intersection with ACEs?
Sure. Good morning, everyone. Thanks so much for having me. I have to agree with you, Beth. I've watched this video now maybe 3 or 4 times, and every time I watch it, it feels like I'm watching it for the first time. It always impacts me, and I always notice something new, right? Or something new sticks with me. So I'm Krystal Rich. I'm the Executive Director of the Connecticut Children's Alliance. Our mission is to end child abuse through collaborative trauma-informed interventions and prevention services. We have 2 main programs. We are the state's membership organization for child advocacy centers and multidisciplinary teams. For those of you who are unfamiliar with those, our CACs and teams are really responsible for providing a collaborative and trauma-informed response and services to kids who've experienced abuse and their families. And more recently, we were fortunate enough to begin a collaboration with the Office of Early Childhood, Prevent Child Abuse America. It's great to be here with you today, Melissa. And several other key stakeholders to become the Prevent Child Abuse Connecticut chapter. It was really through our work in responding to child abuse victims who've already experienced abuse that it became really evident if we want to actually end child abuse, right? Because we all talk about ending it, but it's much more complex than just saying it. And if we really want to end it, we have to focus on prevention. We have to focus on prevention in terms of supporting and enhancing those primary prevention services. And at the same time, we also have to integrate prevention-related reducing that future trauma. And certainly in enhancing ACEs, the ACEs work is a huge part of that. To the question around ACEs data, I have to echo what everyone's saying and agree that it's so critical, I think, for everyone to understand this ACEs data. It provides hope, as described in the video. When we understand why something's occurring, I think we don't feel so helpless. We know how to better respond to people who've experienced those adverse experiences, but then also how to prevent them. I can't help but think of the number of children that we've seen through our CACs when I watch this and think about, what their ACE score was even before they entered our center, and what their parents' ACE scores are. Oftentimes, unfortunately, in the work we see, there's sometimes stigma associated with some of the caregivers, even the non-offending caregivers. And I think if we had a better understanding of even their previous experiences, we'd be able to provide a much better holistic approach. And I think our centers and multidisciplinary teams certainly try that, but it's beyond just that, right? It's the schools, it's the doctors, it's the community, as illustrated in this video, that all have to be on the same page. I think my hope when we talk about using ACEs data across disciplines is that it helps us break down some of those silos that we're all so familiar with. We work in one segment, but really I think what this data shows us is that children experience adverse experiences across their entire lifespan in a whole bunch of different arenas. And if we really want to create a society that has people who are truly happy, healthy, and live productive lives, we can't continue to operate in those silos. I'm going to really have to adopt that kind of multidisciplinary approach for all of this work. So thank you for having me, and I really look forward to the rest of this discussion.
Thanks so much. You all are definitely the right people. You have, I think, probably all of us thinking very critically about all the points that you're bringing up, and I'm so happy that you're each here. Faith, also, I see you there. Please feel free at any point, as you would like to join the conversation. So I guess I would love to start out with one question, which is Dr. Harris Burke in the documentary early on sort of talks about how she transitioned from a pediatrician who just sort of was going through the motions of talking about strictly medicine, right? To somebody who said, you know what, I want to have this conversation with every single family and child that comes in here. And so one of the things that she integrated into her practice was asking every family to complete an ACEs score sheet for the child that she's seeing in that family. And so, one, I'd love to know your thoughts, and this is to Representative Linehan's question also, right? Why don't we integrate that more into multiple fields, but certainly our medical fields? And then the other piece of that is, I'm really acutely aware, even as I took my ACEs, I'm somebody I'm very well aware of the traumas that I've experienced. I have done a lot of work around those traumas. I do this for a living. And seeing, those 8 check marks on that sheet of paper still gives me pause, much like the gentleman who talked about it towards the end of the documentary. So also acknowledging, right, that there is some inherent trauma or, emotional impact for folks seeing that and taking that and walking through that process. So with that understanding, how do you think we could move towards a place where more folks in multiple disciplines are really integrating this into the way that they care for and interact with the families and the children that they work with? And anybody go ahead and start us out.
Yeah, hi, it's Representative Linehan again for everyone. The fact that the doctor did that, to me, just sets off so many things in my head that why can't I write a bill saying that needs to be done? For those of you who may not be aware, I started the Connecticut, why can't I think of the name of it? The Social Emotional Learning Collaborative. Thank you. It just escaped me for a minute. The Social Emotional Learning Collaborative in legislation that I wrote back in 2018, I think, or 2019. And so one of the things that I would like to do is to take that idea to the collaborative and get the backing of the collaborative and actually see if we can't mandate that happens. Because one of the things that we've done already was to mandate suicide screening as early as 3rd grade. And the collaborative said, hey, wait a minute, 3rd grade sounds great, but we think it needs to be kindergarten. And so working towards these things and having this conversation, I think I want to take that idea and I actually want to bring that to the collaborative and hope to have their backing and put forth legislation next year to do that. So that is something I'm actually very interested in doing.
I would just like to chime in here to say, a couple things, reflecting on the question, but reflecting again on what we just saw in the film. A lot of us felt still hopeful, watching a film like that, and certainly being entrenched in this area for many years. Sometimes you flip between hope and hopelessness, right? So let me just be explicit that ACEs are not deterministic, right? So I think some of the pushback that I've heard around the country around ACEs screening is, one, we're screening for all of these negative things, but do we have services in our community to link people to, right? So that's number one. And I think, this conversation is wonderful because you have people across sector and cross agency and service provider and stuff, so that maybe in Connecticut, you're very able to connect and really be able to link to services when you discover a need. But the other thing is comprehensive assessment would also include not just, screening for like sort of these risk factors, or at least what are considered in the literature as risk factors, but also for these buffers and positive childhood experiences. I mean, the science is really strong that it's not just the bad things that happen in early childhood or across the lifespan that stay with you and that can have impacts on your brain, your endocrine system, your immune function, even the way your genes express themselves, but so too can these positive childhood experiences. And Judy Cameron from the Harvard Center of the Developing Child has a lovely graphic that basically shows like a balance. And basically, if you have more good stuff and less bad stuff, then you're more likely to tip the scale toward positive outcomes. And certainly that fulcrum on how many you need changes, right? And those are the structural and social determinants of health and things like equity and systems of oppression and other things. So you may need more in a certain community or in a family to buffer. But there is this movement in the field toward these positive childhood experiences too. And I just encourage us, when we think about ACEs screening or, a number, also understanding that there are these protective factors, and those are at every level, individual level, in the family, community level, but also this socio-political level too. So I'm, so pleased to hear Representative Linehan thinking about this critically and really seeking input, your feedback to make the best laws for your state. So I just wanted to say that there is a lot of hope. But we need to also be seeking that hope as well in terms of what we measure and what we assess, and then what we do about it.
No, I absolutely agree with that. And I also think we've heard from providers as well that, understanding what other assessments everyone is providing and requiring is also critical in that. We've heard from folks that it ends up feeling sometimes like by the time they get to the third or fourth required assessment, it's more of a checkbox rather than actually taking that information and integrating it into how they're providing services for our kids and families. So I think it's that balance of, we absolutely want the information, but how do we make sure that we're not overwhelming both providers and the kids and families that are coming for those services?
Yeah, I think it's I was really intrigued, Representative Linehan, with the doctor who incorporated the ACEs screening, right? Because that is what we'd want to get to, right? We want primary care to be holistic and multidisciplinary and integrated, right? And it's mostly not, right? It's mostly not. Most medical care is not, in my view. And I think we have templates for that I think we can build on and think about, right? So pediatricians are pretty used to screening for, and I know we still have room to improve it. I know Dr. Merrick, I'm sure would chime in on that, but screening, for example, for developmental delays, right? Which is, wired into the practice, right? At 6 months, 9 months, 12 months, the MCHAT now at 15 months and et cetera, right? And then what do you do at the screen? Well, you tell families about Connecticut, you tell them about birth to 3, and then you tell them to call 211 and you talk to them about that screen, right? And so that model works if doctors have enough time and reimbursement to do the screen, right? So we have to think about what is the structure that supports screening and referral, because then a legislative effort could incorporate those pieces. It's what is the time that pediatricians get to meet with children in critical junctures of their life, because 15 minutes is not going to cut it when we want to talk about screening, engagement, and referral, right? I'd love to know how much time, and I'm not going to remember her name, but the doctor in the video, I'd love to know how much time she spends per client and patient, how they bill for that, and then what system of care they're referring to. You see, even in Zoom, can't keep me from not using my hands. All right, I'm a hands user when I talk. I'm a hand talker, right? So it's the time, it's the reimbursement for the screening, and then it's what's the system of care that you're sending to, right? So in Connecticut, you screen for, somebody scores up a little bit on their MCHAT. Well, you're referring to 211 and to birth to 3. That's the system of care that then is going to connect with the family, come to their home, engage, talk to them about, using what Dr. Merrick was talking about, the strengths, the challenges, what the family needs. That is a beautiful system. Right? We don't replicate that. We can though, right? In a couple of ways. One, because, if we think about it in that way, then when we want to integrate ACEs screen into pediatric care, now we're talking to our carriers, we're talking to Medicaid about how to make that happen, right? It's doable. We talk to, there's lots of implications, right? So where's the system of care? OEC is part of that. We even think about our birth to 3 system. We have, like most states, a more restrictive birth to 3 system. We don't have to. We could have a more expansive birth to 3 system that incorporates more of a prevention lens, right? So under federal law, you can serve more kids. You can choose to serve more kids, or you can serve kids who are sort of more profoundly impaired. Kids can also be served through birth to 3 simply for having a social emotional impairment, right? Or a delay, right? So I just think there are opportunities in Connecticut to build on our existing service system, right? And make sure that every community has access to that continuum of services from birth to 3, home visiting plus, which I would call home visiting with clinical supports, and that 0 to 6 sort of continuum of care. So I think there has to be something for the pediatrician to refer to, and we have to make it possible for them to do the screening and engagement and referral. But I think we have models we could build on.
You know, if you don't mind me interjecting here, I mean, I agree with everything you said. One thing I want to point out is the bill that we just passed to eliminate the religious exemption for school-based vaccinations. We did include in that the provision of extra time for pediatricians to discuss vaccines with families, and that it's reimbursable. And so we have, so we have the ability to put that in statute. There's now a precedent. And then I hear what you're saying completely, because just asking the questions and then having it go to this one place and not having a pediatrician know exactly what to do with it. I mean, we're finding that with adults and suicide right now, that, you know, their primary care physicians are asking these screenings, these suicide screenings, then not knowing what to do with it. We had a bill in public health this year that actually mandates suicide screening for adults. And the pushback that we got from the one doctor on the committee was like, well, I don't think it needs to be 100% necessary. And my answer was, of course, it needs to be 100% necessary. I think as a physician, you're not voicing that perhaps you just don't know what to do with it when you get it. So I agree with you that there needs to be that the secondary push to somewhere else, which is why funding care coordinators is so incredibly important. And here in the state of Connecticut, we don't do that. But what's really wonderful is that we're getting a chunk of money from the federal government. And so one of my biggest pushes in the past couple of weeks has been funding a care coordinator service through the United Way and the 211 system, so that we can actually have that done. And so I think that part of the concern is, okay, well, we'll get that money and we'll fund that. And then what happens when the money dries up and then we fall off a cliff? But what my hope is that that we will have this money and be able to fund it for a few years, because the mental health crisis that has been exacerbated by COVID is not going to stop when everybody's vaccinated. So, so we'll have that for a few years. My hope is that we can actually have the data that shows that there is real tangible benefit to this. And so we are the land of steady habits. Change is hard, but I think that when we do have the federal funding in order to be able to do this, then we could, advocates such as ourselves can stand up and say, it's proven that it works. Let's fund it full time. And that's ultimately going to have to be our goal.
Absolutely. I mean, I think, and I love the pieces that you're putting in the chat, Melissa, too, you know, around prevention and dollars. And part of it, you know, when we saw the end of the documentary, the way that they showed in Washington State, right, like all the positive, there were sort of little pockets regionally, but all those positive outcomes. And that's what you need, right? You need success to sell and to create more success. But really having those federal and state dollars dedicated to creating those resources and creating those circles of, you know, that circle of care for children and families is so critical. And it is delightful to hear all of you talk about how possible it is, right? I often sit in spaces where people tell me how impossible things are. And so it's really wonderful to have a conversation where folks are really thinking about and dreaming about the possibilities, you know, that are possible here. So if it's okay with folks, I'll move on to another question. And please, for those of you who are watching along with us, please put any questions you might have in the chat for us. We're certainly reading along all the comments, which I appreciate, but certainly put questions. Faith, is that a raised hand? We can go to you if you'd like.
Yes, I just wanted to add to what you were saying, Beth, is that, sorry, not only is it state and federal policy, it's also philanthropy. And it's one of the things that made Washington, I think, as successful as it was, not only the inside-outside strategy, but really including philanthropy as a key component of, moving the needle the way Washington did.
This is a good time to share, sorry, Beth, this is a good time to share that there is a real cross-sector movement in our country happening. Prevent Child Abuse America, together with the Children's Bureau, the Annie E. Casey Foundation, and Casey Family Programs, have made a national commitment to child and family well-being. It's called Thriving Families, Safer Children. Currently, there's about 23 jurisdictions taking part in this work. There's no specific funds to support this work yet, But all of us have promised to sort of leverage our resources and our networks and our advocacy and everything to try to make investments to support this kind of work. But basically, it's lifting up what's happening already in communities around prevention. And it means integrating lived expertise and family and youth voice into the co-design of the solutions, right? Really helping engage everyone equally to be inclusive of different perspectives, but certainly not just focusing on the usual suspects, right? The usual partners, probably all of us, we would say are usual partners. But what about the business partners? What about the media, chambers of commerce, philanthropy, just cross sector? We all have a role to play in preventing early adversity like child abuse and neglect. And we can, again, achieve multiple of our nation's health and prosperity goals if we do this. So it's something that you all can Google to get more information about which jurisdictions are involved right now. And we hope to have more materials to share soon. But Faith, I think it's absolutely correct that philanthropy has a role here, but we all have a role here. And really, why do we wait until families are in crisis to be able to get the important services that they need, especially in this urgent time of our shared history? Parenting is always difficult and we could all use support all the time, but parenting during a global pandemic, during a moment of acute racial civil unrest, then if it's not now to do something different, I don't know when. So I just wanted to highlight that I think Faith is really onto something there.
Absolutely. Thank you both. I think that that's critical. And I love the idea of, how do we share responsibility, right? Like it is something that as a society and as communities, we have to share the responsibility. And in line with what you all are talking about, I was struck by one of the first stats that was up in the documentary that was $1.3 trillion are spent every single year in the US on healthcare, and only 5% of that is around preventative medicine, right? And that's one specific way to sort of think about that. But again, we as a society, we do not work on prevention, right? And how much we could do to both save dollars, right? If you think about all those later health and other public health interventions, but what it would mean, right? To actually focus on early interventions in kids' lives to not have those long-term negative health, mental health, and other consequences that happen there. So one of the other things I think that's really critical that was highlighted really well in the documentary is that scientific research points to the presence of a stable, caring adult in a child's life as the key to building individual resilience. And so my sort of question for you all, and I think you've hit on some of this in talking about supporting parents and home visits and things like that, but how do you think that providers can most effectively engage parents and caregivers and communities in supporting children who have experienced trauma, especially when so many of those folks are also trauma survivors and might be dealing with multiple current traumas? So how do we really support those families? I think, one of the families in there that the services are being provided by Clifford Beers is a great example, right? You have mom who has acute trauma trying to support a child with acute trauma, and then there's other children and other family members in the mix. So anybody who's comfortable answering, I'd love to hear more about your ideas of supporting those caregivers and parents.
Well, I'm sure there are experts in our audience that might have, the very sophisticated ideas about that. But a couple of things I was thinking about during the documentary in connection with that question, Beth, that I think about a lot is what is our approach to engagement with families and moving away from sort of blame and, again, notions of accountability or traditional notions of what that means. You have to, you must, here's where it's not working, here's what you have to fix. And I think particularly with communities and individuals who have experienced trauma, right? And how people receive that. And and finding ways of engagement that are helpful, supportive, and that offer meaningful help to people, right? And so with I think about the way child welfare has been shifting in a good way, all right, with I think still lots of room for improvement, but when I read records that that have folks going into a home where there are child welfare concerns. I mean, there are concerns, and the family is overwhelmed, and there's very low income, and children have all kinds of multiple needs. And it's like, well, we talked to mom about how she has to clean her house. I mean, next time we come, that house has got to look better than this. It's like, and I mean, I see people shaking their heads, and of course understand, the condition of a home can impact the safety of children. But what do we offer? And then it's like, well, here's your list of services, some of which may be evidence-based that you can participate in. And here are your referrals, and go to your intakes and go do that. And I just don't know that works, right? And coming from a place of how do we help, what is the help the family needs, right? And a place in thinking outside the box of just the traditional evidence-based, and not to diminish the efficacy of some of these services, but that's not the sum total of what families need. That is the sum total of what carriers and insurance will pay for, but that's not always what's needed for families. And I think giving, one thing I just wanted to raise in the context of this conversation is giving providers the flexibility from a funding perspective to work with families where they're at, to meet the needs of families as they present, to provide integrated care that includes, as somebody in the video said, old-fashioned therapy, right? That has value, but also that addresses social determinants of health, right? So that if somebody comes to Clifford Beers for help, they also get, maybe they need money for utilities. Maybe they need some help in the house. Maybe they need access to a camp for one of their children. But thinking about engagement as offering something meaningful to the family to help them live. And from what I understand, the amount of sort of flexible funding that's needed to support integrated care and address social determinants of health is actually pretty low. Those dollars are it's $1,000 per family of flexible funding to support integrated care can make a huge difference in terms of outcomes. But I think, it's changing our mindset to one of support rather than shame and accountability.
I absolutely agree with that. And I think, there's this want sometimes, and rightfully so, when we see that a child is being harmed, or they're having an adverse experience, that we want to go into protection mode. And sometimes that protection mode becomes this where we have this stigma that we put on the caregivers that are there to support the children. And, we all know here, and certainly there's a lot of research that is showing this, that to your question, Beth, if a child has a supportive caregiver and supportive environment, they are going to thrive. And it's finding those, to Sarah's point, those meaningful things that we can do for families. We saw a lot during COVID where, there was providers who've had these policies that, if you no-show 2 times, then you're removed from the list. That's just not realistic. That's not realistic when you have a parent working 3 jobs and has multiple children and may have their own trauma, and maybe they're not bringing their child for services because it triggers them. So it's finding out how to get to that family, how to get to that caregiver and support them where they're at, not where we think they should be. And not treating them like a checklist. We walk through our checklist of questions and we say, okay, we did our safety assessment, we offered these services, but offering a service and making sure, 1, it's a good fit, and 2, that there's access. I think that's the other thing. We put so much on our caregivers to get themselves help, to get their children help. And sometimes the services we're providing have wait lists of 3 months. Well, then what do we expect from them? And it's making sure that they have the support to, support themselves so that they can then show up for their children.
I'm really loving this conversation. And I just think that it points to the fact that we really need a cultural shift. We need to recognize and honor that children are safer with their families than from their families when their families are supported and nurtured and made to succeed. And so the economic supports or concrete supports, CDC lists this as like a key evidence-based strategy for prevention of all kinds of violence outcomes, including ACEs, child abuse and neglect, sexual violence, youth violence, suicide, intimate partner violence, right? So concrete support's so key, especially as we think of neglect being really the overwhelming majority of the cases that we see in child welfare every year. And this, distinction between neglect and poverty is still one that our nation has not gotten right. So I think it is also, I agree, Krystal and Sarah, it's not just about risk assessment, but we are a field that we were born out of like knowing a whole lot about risks. And so we're so kind of acculturated to like, okay, risk reduction, as opposed to the promotion of good stuff, the protective factors, the protective context. So really asking families to, what are the assets? What are the strengths that they have? Identifying those family strengths. I know in my own time in child welfare as a postdoc in Miami, it was like we'd have all these risk factors listed, and then maybe we'd have like, oh, we also need to identify a family strength. And we'd say, okay, parents are employed, or, grandma lives at home too, right? And we'd like tack one on. And it's sort of like how we treat prevention in much of our legislation too. We talk about treatment and then we tack on the word prevention as if that means anything different. So I think it's really around, yes, meeting families where they are, but that means we have to listen humbly, right? We have to listen and truly like have the solutions come from that lived expertise. And I don't think that we've always as a field been very good at that for a lot of reasons, reimbursement, time, all of the, and many others, but also really not valuing the expertise of our families, of our moms, of our communities, right? Thinking that because we have the degrees or we have the whatever, that we have all the answers, but we obviously do not, because we still have this big problem in this country. But it is preventable. And I see a lot of great stuff in the chat about how preventable and hopeful it is. We know what can work if we all take, play a role in this important public health moment.
I'm sorry.
Yeah, I was just thinking, I've seen the movie a couple of times, and one of the things that struck me, perhaps more this time than others, and what Dr. Burke had said, is how many kids are on medication. And I think if we actually did an ACE score prior to actually giving these children medications, then we would know why we're considering giving them the medication. And the medication's not going to work for their trauma. So, even sort of coming back to, I just think of case records that our office looks at across the domain. How many kids are on medication, how many kids psychiatric medication is being prescribed by pediatricians, that there's no, when we think about going back to sort of root causes, we'll spend 5 minutes to try to figure out, oh, okay, you have ADHD or you have an emerging whatever psychiatric disorder we may think that those children have. But in fact, if we actually did some root cause work and go back and maybe even screen them around ACEs, I think our whole approach to those children would be radically different.
Absolutely. I think that that's a critical piece to consider also. And I love all the things that you all are bringing in, again, in terms of what is possible and sort of how we can get there. One of the things that I love to also talk about in the documentary is the places where we can have innovation, right? I think many of you are talking about that already. Representative Linehan, as she put in the chat, had to pivot off for an 11:30. We're going to keep talking for a few more minutes with the rest of our panelists. And so one of the things that was highlighted was a PTSD clinic, which I actually, when I was a rape crisis advocate, it's the PTSD clinic that I worked with out in New Haven. They partnered with a school in New Haven and developed that Miss Kendra curriculum. And so it was a way that they really identified to be able to use what they call drama therapy to engage kids and have kids open up about their experiences in a way that you could build in adult, caring adult interventions, because they would know about what was happening, but also just sort of let them still be kids in those conversations. They got to express it as children. You saw it through their drawing and their writing. And it was something that, as you could see with those kids, was just such a positive experience. It wasn't somebody trying to sort of poke and prod and find out what was wrong with them. It was them in a really child-friendly way being able to talk about their experiences and what was happening in their lives. And so I'd love to hear more about how you all think we can drive support and resources towards that kind of innovative programming, right? We know we need more data. We know we need systems to talk to one another. We need those care coordinators. But this kind of programming for me is a really unique thing. to think about that also has a really important place. And so I'd love to hear more about what you think, where are the innovations and where are the places that we can build support for things like the Miss Kendra curriculum. And again, anybody, please feel free to start us off.
I mean, I think one of the things, Beth, that we really need to continue to do to build this innovation or agency's ability to come up with some of these innovative programs is continue this conversation in a very thoughtful way throughout the year. I think we've known ACEs, this data has been around for a long time. A lot of the information that we see that we saw on the film Resiliency, we've heard about, but I feel like we have this conversation. And it's great to see the legislation, and I think we are in a different place than we ever have been, but we've got to continue that push. And we've got to continue raising the bar and I think educating, do more of what, you all put on this, having this panel, do more trainings, identify what else is going on in other places of the country, focus on or highlight some of those programs, like the program out of Clifford Beers, on a continuous basis. And I think that's when people will start to think more about some of these innovative practices, and maybe more funding and resources will start to open up for these programs.
I was going to add to that, Krystal, just, I think there's sort of the big things. I think, there's lots of, Connecticut has some real pockets of excellence in terms of what's going on in many, many districts. Representative Linehan talked about the Social Emotional Learning Collaborative, which often highlights some of those things that are happening within communities and districts. But from the work with the Office of Early Childhood through, Krystal's agency, having small innovative grants for communities to have $5,000 to do something within that community, or $15,000 to do something within that neighborhood. Some of these things are not like these huge heavy lifts. They're, having the community say, this is what we need, and can you help us fund this? And what communities say they want is, like, if you could give us $15,000, they could practically work a miracle there, and it's, I don't think we're engaged enough with some communities around, what is it that you want for your community, and how can we help, lift and elevate that for you with a little bit of money.
No, and it's true. I think that's a great point, Faith. In those community grants, what's interesting is, to your point, people have done a lot of great, research, implemented programs and trainings for $25,000. But what was key in that is, because of our relationship with the Office of Early Childhood, there wasn't a lot of restriction on what they were able to do. And so I think that allowed them to be creative and kind of come up with some of these programs that met their community specific needs. But it's doing more of that. It's trying to figure a way to make sure we're sharing information in a centralized way somehow, but also allowing communities to come up with these innovative practices that meet their needs.
Absolutely. I think that is critical. So as we wrap up today, I want to thank all of you for being here. I want to leave you with a couple of requests. One, first, our team put in a evaluation. We love having these conversations. We want to hear what is helpful to you about these conversations, what you'd like to see us do more of. So please just take a few minutes to fill out that evaluation for us. I also want to invite everyone to another session we're hosting tomorrow as part of our SAM events with Together for Girls, where we'll focus on ending child sexual abuse through the lens of prevention, healing, and justice. So it really is a great segue from today's conversation into tomorrow's conversation. If you go to our website at www.endsexualviolencect.org, you can find some more information and how to register there. And again, I was so delighted to be part of this conversation. I could listen to all of you talk all day, every day. Thank you again to Sarah Eagan for being here, Krystal Rich, State Representative Liz Linehan, Melissa Merrick, and Faith Voss-Winkle. I appreciate you all so much. The work you are doing is amazing, and you all put us in such great company today. So thank you again. I hope everyone has a great rest of your day, and I hope we all find ways to really support the children in our lives. Thanks so much, everyone.
Right.
Thanks,
Thank
Beth.
you.
Thanks for letting me be an interluder there.
My pleasure always, Faith. You're always a joy to be with.